All right, there we go. I'm Dr. Janique Bailey, and I'll be hosting today's session. And we are grateful and extremely privileged to have Professor Adam Back give a lecture today. This will be a third in a series of lectures on this platform. And today's session is titled Genetic Testing of Small B-cell Neoplasms. But before I introduce Professor Back to those who have not met him just yet, I would like to touch on some housekeeping rules. Firstly, the recordings for this session and previous sessions can be found on the Blood is A website under the resources. For any questions or comments, please add these to the chat box. I'll keep an eye on the chat box throughout the session. And then to be added to the mailing list, please email Melanie Davids. There we go, Melanie Davids here. And in terms of CPD points, this will be automatically submitted to the HPCSA for each South African attendee. Please ensure that you are attending with your own registered Zoom account and not in a group. So please just mind that. And then for any CPD queries, or if you need a CPD certificate for those outside of South Africa, you can email Melanie Davids as well. And 1 hour attendance required to qualify for CPD point. There will also be an option to give, or the option to give anonymous feedback. There will be a survey pop up after the session. Please be so kind as to complete this. In terms of upcoming conferences, the South African Society of Medical Oncology, in collaboration with the South African Stem Cell Transplant Society, is hosting a third joint conference at the CTICC, so this will be next week. We've also got the 14th International Donor Registry Conference and WMDA meetings at the end of June, as well as the 16th Annual Hematology Oncology Symposium in September. For links to these meetings, kindly refer to the Blood is A website. And then I would like to thank the management team for all the work you do in background, in particular Estelle Verbeer, Khadin, and Melanie Davids. All right, so today's session is on genetic testing of small B-cell neoplasms, and then this will be followed on the 8th of April on germline predisposition and myeloid neoplasms. All right, so our speaker today, Prof. Adam Back, for those who have not had the privilege of hearing him speak previously on this platform or any other, Prof. Back went to medical school and trained in hematopathology at Wits. He is currently Professor of Pathology and Laboratory Medicine at the University of Pennsylvania in Philadelphia, United States. He has been on sabbatical here at UCT, and for the past 15 years have been voted by his peers as one of Philadelphia's top doctors. In 2012 and since, he was noted by US News and World Report to be in the top 1% of doctors in the United States. Prof. Back has lectured extensively in the USA at prestigious meetings as well as institutions, and internationally, very well-known meetings as well in over 20 countries. He has over 240 publications, and many of these on molecular pathology of hematological malignancies. And perhaps I can just add, he's an all-round enjoyable person. We've really have been very privileged to have him at UCT. We've enjoyed you, Prof. Back, and thank you very much for imparting all your knowledge. There we go. I'm going to hand over to you. Thank you very much.
Thanks very much, Janique, for the kind introduction. And just to reiterate what I've said before, I wanted to thank you and everyone at UCT for being such wonderful hosts. I've had a great time. Let me figure out how to share my screen. This will stop the other screens sharing. That's okay. Do you want to continue? I'm going to say yes. And I'm going to click there. And hopefully that'll bring up a black screen. Can someone confirm that you just see a completely black screen?
We can see it.
Yes,
yes, thanks.
Thanks. And you can hear me.
Yes,
Yes,
you
we
can.
can.
And you can hear the seagulls in the background. I've got seagulls on the left and seagulls on the right, who will be interjecting now and again. All right. Thanks again very much. The topic for today, as advertised, is the role of genetic studies in small B-cell neoplasms. A fairly boring title, so I think perhaps a more creative or perhaps silly title is B-cells behaving badly, a better basis to behold belligerence in small and usually, but not always, indolent B-cell neoplasms. And going along with that alliterative title, for the purposes of today's talk, I'll be using my street name, Bad Boy Bag, and I hope you will refer to me as such at question time and in the chat. Now, if you think that's an abject and absolutely annoying abuse of alliteration, you would, of course, be entirely correct. But you should also be thankful that I'm the fill-in speaker for today. The originally slated speaker was the Reverend James Nelson Hume, a world-renowned hematopathologist known to all of you, I'm sure, who originally wrote the book on alliteration. And in this book on alliteration, there were more than 2,000 words, each word beginning with the letter A. Unfortunately, the very Reverend couldn't be with us today, as in fact, he is sadly departed. So I'm filling in for him. Some of the objectives I wish to cover today and mention of a conflict or no conflicts. So in terms of disclosures, I have no conflicts of interest as it pertains to the contents of today's talk. What I intend to do is to describe the genetic features in general terms, and then with a little bit of a deeper dive on some topics regarding the genetic features of small B-cell neoplasms. I hope to discuss the role of genetic testing in clinical practice in small B-cell neoplasms and determine which genetic tests are indeed of value in routine clinical practice, and then ultimately hope to distinguish those tests that are of diagnostic value from those that are prognostically relevant. Much of the immune repertoire that we can generate, and specifically in terms of B cells rather than T cells, relates to the malleability of the immunoglobulin genes. So as you know, when a B cell traverses initially the bone marrow and then subsequently circulates in the blood as a mature B cell and enters the germinal center, it undergoes a number of different changes and names, from precursor B cells to naive B cells to circulating naive B cells, within the germinal center to centroblasts and centrocytes, and ultimately seeing out their days as memory B cells or plasma cells. However, this pathway is not completely unidirectional, as I've illustrated here. Certainly within the germinal center, it's been recognized that there is a lot of back and forth between centroblasts and centrocytes. And in addition to that, memory B cells don't just hang out in the periphery on their own. They often recirculate and re-enter the germinal center many times, exposing them to the treacherous environment therein. The immunoglobulin genes are malleable at the initial stages of development due to physiologic VDJ rearrangements, important first step in the generation of immunologic diversity, mediated, as you know, by the enzyme complex RAG1, RAG2, recombinase activating genes 1 and 2. When the B cells hit the germinal center, they subjected to two further stages of physiologic DNA damage, first with somatic hypermutation and then with class switch recombination, SHM and CSR respectively, which are mediated by the AID, activation-induced cytidine deaminase complex within the germinal center. And then there's a fourth time when DNA changes occur, and this is in the bone marrow of B cells and the thymus of T cells, although we're not covering T cells today, and that's through the action of the enzyme TDT, terminal deoxynucleotide transferase, which adds and subtracts nucleotides in a template-free fashion. But these good intentions of the immunoglobulin genes can go bad. So we know, for example, errors in VDJ recombination can lead to the translocations we see, for example, in follicular lymphoma and mantle cell lymphoma. Errors in recombining after somatic hypermutation could lead to translocations seen in Burkitt and diffuse large B-cell lymphoma. Similarly, errors in class switch recombination repair also can lead to different flavors of diffuse large B-cell lymphoma, Burkitt lymphoma, and indeed also multiple myeloma. Now, whereas we associate these three lymphoma subtypes, follicular lymphoma, mantle cell lymphoma, and Burkitt lymphoma, bolded in blue, with their sort of canonical translocations involving BCL2, cyclin D1, and MYC, respectively. An important point to consider is that unlike many B-cell neoplasms, such as chronic myeloid leukemia, many AMLs nowadays, the mouthful of a category MLNE-TKGF, standing for myeloid and lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions, as well as many acute lymphoblastic leukemias, none of these diagnoses require a genetic test to make the diagnosis, number one. And number two, none of these genetic abnormalities that we prototypically associate with these lymphomas is 100% diagnostically sensitive or specific. So there are examples of these lymphomas that lack these canonical translocations, and occasionally these translocations can be seen in other lymphoma subtypes. In fact, unlike many of the entities summarized in the orange bar at the bottom, there are today very few genetically defined lymphomas, although I think we are poised to move more into genomic-based classifications in the future. And so the handful of genetically defined lymphomas are restricted to, for the most part, that subtype of high-grade B-cell lymphoma, HGBL, that's defined by a double or sometimes triple hit. ALK-positive anaplastic large cell lymphomas are, of course, genetically defined, but you absolutely don't need to do genetic testing, since we have a wonderful immunohistochemical surrogate for the ALK translocations. IRF4 translocated large cell lymphomas are defined by the presence of this translocation, although somewhat curiously, if you read the fine print of the classification schemes, you don't need to show the translocation to diagnose this entity, which is a little bit challenging to get wrap one's head around, although you can sometimes test for mutations, which is not widely performed. And then finally, there's the entity of large B-cell lymphoma with 11 Q aberrations, gains, and losses on the long arm of chromosome 11. But here again, there's no well-defined genetic test. Indeed, the genes involved still remain somewhat enigmatic, and there are some sort of crude FISH assays or sometimes array CGH that can be used to diagnose this entity, and not widely available. Although VDJ rearrangement going awry can lead to, and usually is the usual underlying mechanism for the 11-14 translocation in mantle cell lymphoma, it's also been shown recently that this translocation in mantle cell lymphoma can occur later on in the germinal center, for what that's worth. So, under the menu of small B-cell neoplasms, we can consider, and indeed we will consider, many of these entities as listed here. I'm going to talk about CLL, SLL, hairy cell leukemia, lymphoplasmacytic lymphoma, marginal zone lymphoma, follicular lymphoma, and mantle cell lymphoma. I will not be talking about prolymphocytic leukemia, since the obituary for this disease has largely been written in both ICC and WHO classification schemes, and neither really considers it an entity anymore. As you know, these small B-cell neoplasms generally have in common the following features. They tend to present at an older age, so are only uncommonly diagnosed in the pediatric context. Many, but not all, tend to be more common in males, and they in common have, from an immunophenotypic and almost functional B-cell perspective, an expansion of mature B-cells, mature being defined by the presence of surface membrane immunoglobulin, that typically is monoclonal when looked at light chain restriction, and all have a variable proclivity to involve the marrow and blood, although many initially present in lymph nodes and may sort of be first encountered by anatomic pathologists rather than hematopathologists. And so here are the entities we're going to talk about today, from top left to bottom right. Top left, we've got a classical low-power view of follicular lymphoma with back-to-back homogeneous looking follicles, followed in the center of the top by the pseudofollicular proliferation centers of small lymphocytic lymphoma / chronic lymphocytic leukemia. Top right, a marginal zone growth pattern, a mantle zone growth pattern, of a mantle cell lymphoma. Bottom left, a rather sizable biopsy, uncommonly encountered nowadays, of a gastric malt lymphoma or extranodal marginal zone lymphoma. To its right, small lymphocytic lymphoma circulating in the blood as chronic lymphocytic leukemia, followed by lymphocytes and plasma cells and in-between cells in lymphoplasmacytic lymphoma. And finally, on the right, hairy cell leukemia. And I show this slide because despite all the genetic advances that have been made recently and indeed remotely, we are still highly dependent upon the morphologic, be it cytologic in a bone marrow or peripheral blood, or FNA on a cytology specimen, or ultimately on an excisional biopsy of a lymph node, on these features that we need microscopes for. And, you know, despite the threats that immunophenotyping on the historically and more recently genetic testing would make pathologists, microscopic-based pathologists redundant, I think that's not likely to happen, at least not in the foreseeable future. So let's spend a little bit more time talking about follicular lymphoma and its association with the 14/18 translocation dysregulating BCL2 expression. So to expand upon a point I made earlier, not 100% of follicular lymphomas have the 14/18 translocation. Depending on your denominator, roughly 85% do. And indeed, not all lymphomas that harbor this translocation dysregulating BCL2 turn out to be follicular lymphomas. The same translocation can be seen in apparently de novo diffuse large B-cell lymphomas and indeed other lymphoma subtypes. A wonderful tool for immunohistochemistry is BCL2. But importantly, BCL2 overexpression does not distinguish follicular lymphoma from other small B-cell lymphomas, all of which can and usually do overexpress BCL2. So finding BCL2 on a B-cell is not a feature, a characteristic or specific feature of follicular lymphoma. However, we use immunohistochemistry for BCL2 perhaps in the setting to distinguish in challenging cases reactive follicular hyperplasia from follicular lymphoma, in which the expectation is that the follicular lymphoma cells will be positive, whereas the reactive germinal center B cells will be negative for BCL2. In rare instances, or perhaps not that rare, if you go looking for it, you may find by FISH, if you choose to do it, and certainly not necessary in all cases, that the FISH shows that there's a 14/18 translocation, and yet immunohistochemistry is negative for BCL2. The typical explanation for this is the acquisition of a point mutation in the BCL2 gene that abrogates an epitope that is recognized by the common monoclonal antibody that is used by most laboratories. This is quite a common phenomenon, but there are alternative antibodies available to pick up the BCL2 overexpression. This BCL2 mutation is associated, however, with an increased risk of progression or transformation to a high-grade lymphoma. There is a theoretic, although not observed, clinical concern about developing resistance to BCL2 antagonists, which are not widely used nor effective in this lymphoma. Speaking of mutations, there's a 7-gene risk model that are used in some clinical trials, although not yet used clinically, that you can use looking at mutations at this array of genes to provide prognostic information. So if we said 85% have the 14/18 translocation, what about the other 15% plus or minus that lack the translocation? Some may still be BCL2 protein positive due to the presence of increased copy numbers of chromosome 18 or the BCL2 gene itself. In the remainder, BCL6 translocations are the second most common translocation, and these cases will be BCL2 negative, and they tend to be MUM1 positive, usually not seen in follicular lymphoma, grade 3 cytology, predominantly large cell, CD10 negative, and tend to have an aggressive clinical course. And allied to this, there is now recognized a growing list of follicular lymphomas that are actually defined by the absence of the canonical 14/18 translocation. So, for example, primary testicular, primary cutaneous, pediatric type, and diffuse inguinal, amongst others, follicular lymphomas are characteristically negative for this classic translocation. And that's important to be aware of. And rather than having this translocation, they are typically associated with, for example, in the primary inguinal form, diffuse inguinal form of mutations of TNF receptor superfamily 14, STAT6 or SOX1. By contrast, primary cutaneous cases tend to have TNF-ARP mutations. Pediatric type tends to have MAP kinase mutations. It's also become clear that follicular lymphoma has more to it at a genetic level than just BCL2 dysregulation. And a common overreaching phenomenon at a genetic level in these cases is the presence of mutations in histone-modifying genes, some of which are listed here: KMT2D, formerly known as MLL2, CREB-BP, EZH2, EP300, and MEF2B. And you can see their relative frequencies are listed there. Interestingly, it's thought that the 1418 translocation is the initial event in follicular lymphoma. It may not be. Sometimes CREB-BP, an early event, can precede this. EZH2 mutations seen in about 20% of cases are of relevance therapeutically nowadays, in that there is the availability of EZH2 inhibitors, tazemetostat. Apologies for the barking dog in the background. If you can hear that, that's the noisy neighbors. Anyway, the efficacy of this inhibitor is about 70% in follicular lymphomas that harbor the mutation, but interestingly, wild-type cases respond as well, although less so, at about 35%. A number of genomic subgroups have been identified in follicular lymphomas, depending on which genes are mutated and whether there is or not aberrant somatic hypermutation. One of the feared consequences of follicular lymphoma, of course, is progression to large B-cell lymphomas. And interestingly, it's been shown that this progression is not a straight line. It's not as if there's an initial hit, then you get follicular lymphoma, and out of that comes a diffuse large B-cell lymphoma. It appears that there's a common precursor with divergent progression to the diffuse large B-cell lymphoma, a common precursor cell that can, on the one hand, spawn follicular lymphoma, and on the other hand, diffuse large B-cell lymphoma, without having gone through the follicular lymphoma phase. It would be nice to know from a genetic level or any level if we could predict progression to diffuse large B-cell lymphoma. And in addition to BCL2 mutations, as I mentioned earlier, a number of other genetic events, when present at diagnosis, may predict subsequent evolution. At the time of evolution, of course, there are a number of other genetic changes that occur that may be evident if you test for them. Another way of looking at this is that it's recently been identified by the group from British Columbia, two mutational subgroups in follicular lymphoma, which they term so-called constrained follicular lymphoma, or DLBCL-like follicular lymphoma. And looking at certain genes, those with the CREB-BP cat domain mutations tend to have the constrained form, and they had diminished levels of aberrant somatic hypermutation. And patients with this genetic profile at diagnosis had a decade delay in transforming to diffuse large B-cell lymphoma, as opposed to those who had the DLBCL-like follicular lymphoma subtype. When they transform, you'd logically expect that the diffuse large B-cell lymphoma would have a GCB profile, be it genomically or by the more simple, albeit flawed, Hans immunohistochemical algorithm. And yet 15% of cases of transformed follicular lymphoma actually have an ABC profile, activated B-cell profile. And interestingly, this is associated with mutation in genes such as CD79B, MYD88, and BCL10, which are known to be mutated more frequently in the setting of de novo ABC, diffuse large B-cell lymphomas. Pediatric type follicular lymphoma is an interesting subtype of follicular lymphoma, and I've tried to summarize in this table the differences between the classic adult form and the pediatric type. Obviously, the age is an important variable, the adult type in older individuals, pediatric type, not exclusively in the pediatric context, but certainly enriched in young adults as well. A very striking male predominance in the pediatric type, not evident in the adult type. Whereas adults tend to usually present with disseminated, a high stage disease 3 or 4, it is usually localized in the pediatric type, and the opposite is true with regard to grade. Most adult cases, lower grade 1-2, higher grade in the pediatric type. As you would predict, BCL2 immunohistochemistry is positive in most adult types because of the translocation, and yet is negative in the pediatric type because they lack that canonical translocation. Somewhat allied to the cell grade is that Ki67 proliferative fraction tends to be low in the adult form, higher in the pediatric form. And as noted, the translocation, especially of BCL2, but also BCL6 and less commonly MYC, are found in the adult type, and yet none of these three is evident in the pediatric type. Copy number variants more common in the adult type than the pediatric type. allied to the genomic complexity of follicular lymphoma. And the mutations that are enriched in the adult type, as we mentioned, are the histone-modifying genes KM2D and CREB-BP, whereas in the pediatric type, you're more likely to encounter MAP kinase and IRF8 mutations. Clinically, the adult type is incurable generally with relapsing and remitting disease with a concern for progression, whereas the pediatric type tends to be curable with local therapy, be it surgical incision or sometimes a dose of local radiotherapy. Chronic lymphocytic leukemia usually comes to attention in the hematology laboratory rather than on biopsies, of course, and characterized by the expansion of mature appearing lymphocytes that are fragile, that tend to pop open to give you smudge cells or basket cells, although not terribly well illustrated in this image. The chromatin pattern of CLL is highly characteristic and useful to pay attention to on a peripheral blood smear, less evident in biopsies, so-called soccer ball or football chromatin more appropriately. Cracked mud chromatin is a term that's also used, and also ginger biscuit or an American ginger snap abnormalities are described, reflecting the characteristic chromatin you can see in CLL. Of course, CLL, the phenotype is usually quite classic, monoclonal B cells co-expressing CD5 and CD23 with dim immunoglobulin, dim CD20, amongst others. More recently, CD23 has largely been supplanted by the use of CD200 by flow cytometry, and in tissue sections, ALIF1 is a useful immunohistochemical marker to help distinguish from mantle cell lymphoma in tricky cases. In about 5% of patients, presentation will be with lymphadenopathy rather than with circulating disease, so-called SLL, or small lymphocytic lymphoma components, and as illustrated here, characterized by the sort of vaguely nodular pseudofollicular proliferation centers, imparting what has been referred to as a cloudy sky appearance, in contrast to the starry sky appearance that we all know and associated with Burkitt lymphoma. This observation of pseudofollicular proliferation centers was of interest historically, sort of faded out of reports for a number of years, but has become more relevant recently with the reports that if these pseudofollicular proliferation centers are confluent and are larger in size than a 20x microscopic field, they actually portend more aggressive disease. CLL is not a monolithic disease. There are many, many ways in which the disease can manifest or progress. And there have been attempts over the years to unravel or predict the heterogeneity. Conventional parameters that were used historically and are still used today, the Leray classification, the Binet classification systems have been aided and abetted and expanded upon looking at novel or really novel-ish parameters. These are not brand new, but I think we continue to learn new things all the time. So those include cytogenetics, cell of origin, and mutations. With regard to cytogenetics, this is the classic carrier type that I think one is most likely to encounter in the setting of the chromosomal analysis being performed on a CLL specimen. And I know David Richardson, who is in the audience watching this, can, after all the time we've spent together and the time he spent learning of chromosomes and their value, can shout out what the abnormality is in this carrier type. You're absolutely correct, David. Thank you for that. This is an absolutely normal carrier type, and that's exactly what you would expect in a typical analysis of a patient's peripheral blood specimen with CLL. The CLL cells tend not to like to divide and will normally give you normal metaphases of background cells. So one has to ultimately go fishing. And the number of recurrent cytogenetic abnormalities, largely numeric rather than translocations, are encountered. For example, deletion 13q14 is the most common abnormality detected by FISH, which is seen in over 1/2 of cases. The second most common abnormality, deletions of 11q22 in roughly 1 in 5 cases. Trisomy 12, which until the advent of the use of FISH was the most common cytogenetic abnormality, now relegated to third with FISH testing, seen in about 1 in 6 patients. And then the fourth most frequently, at least tested for cytogenetic abnormality, is deletion of 17p13. That has a very variable frequency, as we'll see, roughly 7% overall. And of course, the importance of doing FISH analysis is for prognostic reasons, not for diagnostic reasons. Not a single one of these abnormalities is absolutely specific for CLL and can be seen and is indeed seen across the spectrum of small B-cell neoplasms. But they are very important prognostically, as you know, and this was initially identified by Hartmut Donner in this paper roughly a quarter of a century ago, showing that the worst type of cytogenetic abnormality detected by FISH is the deletion of 17p, and we know that the gene that is disrupted or lost through this is TP53, the tumor suppressor gene. The second worst deletional event is 11q deletion, taking out probably ATM. Finally, 13q deletion as the sole abnormality is associated with the best prognosis of all. Indeed, having the 13q deletion, patients with this have a better prognosis than those who have a normal panel. The 13q deletion, while typically associated with a good prognosis and associated with the loss of 2 microRNAs, 15A and 16-1, is not always good. If you have a very large deletion in this region encompassing the ARBRI1 locus, for example, or if the abnormality is seen in more than 70% of nuclei, the 13q deletion actually is a bad prognosticator. What about cytogenetics? Well, as I mentioned, the CLL cells are fairly quiescent. They don't like to go into cycle and need a bit of nudging or tickling to move forward. And one of the mitogen that's used to tickle B cells are CpG dinucleotides. And so it is possible to coax them into generating metaphases and a karyotype. Immunoglobulin translocations, unlike many of the other small B-cell lymphomas, are rare, but they're generally bad unless BCL2 is involved, in which case they're not so bad. And this also highlights the fact that BCL2 translocations are not specific for CLL, for follicular lymphoma, excuse me. Chromosomal complexity, karyotypic complexity is relevant if you find 3 or more abnormalities, which can be seen in up to 10% of patients. This is bad. People are now distinguishing complex from very complex, depending on the number 3 or 5 or more abnormal clones detected. Comparative genomic hybridization can certainly pick up more abnormalities than FISH, as you would predict, because this is a non-biased way of looking at the entire genome. And it's done by some laboratories. The lab I work with, don't do this. There hasn't been a calling for this, and yet it can pick up many more abnormalities than very focused FISH can pick up. With the advent of targeted or not targeted, with whole genome sequencing and analyses by a number of scientific interventions, a long tail of gene mutations has been described. And so over 2,000 different genes are described to be mutated in CLL, of which roughly 75 are determined to be biologically significant, and 35 of these occur at a frequency of more than 1%. These are the big 4 genes that are mutated in CLL: TP53, ATM, Notch1, and SF3B1. The top 2 we've talked about already. The bottom 2, Notch1, we first came to learn about in T lymphoblastic lymphomas, of course, and SF3B1 in refractory anemia with ring sideroblasts, here also playing a role in different neoplasms. The big 4 each can occur in roughly 5 to 15% of cases. The mutations of TP53 and ATM are often accompanied by deletions of those genes. And here are some of the other genes, and there are many, many more, that can be mutated in CLL. And if you can think of your favorite gene that's probably mutated in CLL, and as a general rule, any of these mutations is associated with a poorer prognosis. The one interesting exception is mutations of MYD88, which we characteristically associate with another B-cell neoplasm we'll get to shortly, tends in the context of CLL to be associated with a good prognosis. Also importantly, not at the time of diagnosis necessarily, but in patients being treated, is the detection of BTK mutation and phospholipase C gamma 2 mutations that are enriched in patients who've been exposed to BTK inhibitors, with the tumor now becoming aware of the negative effects on its life if BTK is inhibited. So it either develops mutations in BTK that don't allow the drug to bind, or by activating a downstream element of the pathway, phospholipase C gamma 2, resulting in resistance to this, what has otherwise been a very effective drug in this disease. And this is seen in up to 70% of patients with resistance. As you might predict, it can be seen before overt clinical relapse. But it's not the only cause of resistance. There are other causes of resistance in patients with CLL outside of the BTK pathway. What is BTK? BTK is quite an interesting molecule. It's involved in B-cell development. It's involved in B-cell signaling. But BTK should not be confused with BTS. And I know there is a tendency among certain groups to confuse the two. Of course, BTS, as I think most of you will know, refers to perhaps the most popular K-pop group in the world, as illustrated here. And I'm showing this not just as an interlude, because every now and again, certainly in the American board exams, and I suspect also maybe in the South African college exams, you're asked to identify the individual members of BTS. So I just want to spend a bit of time on the slide to make sure you're able to distinguish Jungkook from Jimin from RM. I'm sure most of you can. I know definitely Rory Shane, if you're on the call, you're all over this. Now, of course, BTS should not be confused with XO. And again, I know everyone attending this talk is aware of this, but XO is another, I think, fairly talented group of musicians from Korea, another K-pop band. I know I was, and I suspect you were too, very, very disappointed, in fact, devastated when the lead member of this K-pop group left the group a few years ago. And after some time and some search, they managed to find a fairly suitable substitute. And fortunately, this boy group is back together again. All right, moving along with CLL, SLL, what a little bit more on TP53 mutations and deletions. So roughly 90% of the patients with the deletion also have the mutation. Fewer with the mutation have the deletion. For what that's worth, you can sort of think of the chronology of these two events that often occur together. I did mention earlier that TP53 deletions occur in about 7% of cases, but the frequency of mutations varies quite tremendously. Whereas 5% of patients at diagnosis, unselected patients, have TP53 mutations, by the time they first appear in your clinic needing therapy, roughly 10% will have a P53 mutation. Roughly a third at the time of relapse or refractory disease will have a P53 mutation, and fully over one half will have P53 mutations at the time of diffuse large B-cell lymphoma transformation. It's currently recommended that you determine the variant allelic fraction of the mutation with this and other mutations in other diseases, and the current recommended VAF is greater than 10% to acknowledge TP53's role in the biology of this disease. However, that might be a very, very conservative level, because minor clones, even those are less than 1%, also appear to be clinically relevant. And maybe the guidance will change in the not too distant future. It's important to recognize P53 mutations, not only because this will predict aggressive disease, but it also may predict response to the BCL2 inhibitor of venetoclax. However, just as is almost always the case in these targeted therapies, resistance develops. And in this instance, resistance develops due to the acquisition, unsurprisingly, of BCL2 mutations that prevent the ability of this drug to bind. But there are other mutations that might be acquired or other genetic abnormalities that will overcome the blockage in BCL2 overexpression in these TP53 positive cases. If you've spent the last 10 minutes on which I've been talking about CLL, dozing off or catching up on other work, I don't blame you. But I think if you could just focus on this very simple cartoon here, that'll give you a very simplistic view of the underlying genetic abnormalities and pathways that are disrupted in CLL. But CLL continues to be an extraordinarily complicated disease. A more recent publication showing the list of genes that are mutated in CLL and their frequency, and a circus plot on the right illustrating the connectivity and association of some of these mutations in this extraordinarily actually complicated disease. With regard to the cell of origin, the dogma historically has been that CLL is a neoplasm of naive B cells, in other words, B cells that have yet to encounter antigen. But to paraphrase one of my favorite bumper stickers, the karma has run over this dogma. And so there's the original car, there's the karma police, another a little tidbit for many of you in the audience to associate with. And that obliterated the dogma. So sadly, bye-bye doggy and bye-bye dogma. What I mean is when a number of groups, and again, 25 years ago, this is not brand new stuff, but continues to be unraveled, the expectation was that the immunoglobulin genes in CLL specimens would be non-mutated, indicating that they had not yet hit the germinal center, consistent with so-called naive B cells. But it was shown that roughly 1/2 of CLL's immunoglobulin genes was mutated, providing a visa stamp of sorts in the passport or the travels of that B cell that it had been through the germinal center. And this was consistent with memory B cells. And aside from the interesting biology of these two flavors of CLL, more importantly, from a clinical perspective, was the impact of somatic hypermutation on prognosis. Those without somatic hypermutation, unmutated immunoglobulin genes, the solid curve on the left, had a median survival of 7 years in early stage Bennet disease. Those with mutated genes in the dashed curve on the right, on this Kaplan-Meier curve, had a median survival dramatically different at 25 years. So there was a huge difference in the outcome, never mind the interesting biologic discovery. At the time this was known and published upon, we didn't have next generation sequencing. As I said, this was 25 years ago. And so people looked, and it was difficult to measure immunoglobulin gene somatic hypermutation. People looked for surrogates for the absence of somatic hypermutation. One that was proposed was CD38. It came and went as a surrogate. Another one that came and went was ZAP70, perhaps an independent prognostic variable, but that's not really tested for in laboratories. But now that we can do somatic hypermutation in a more facile manner through next generation sequencing, those surrogates are no longer important. You'll also note on the top right-hand side that I have naive in inverted commas, but in fact, when people looked at the gene expression profile of those so-called naive cells, they actually have a gene expression profile of memory B cells. So now CLL is suddenly a disease of memory B cells. Well, you may ask, how can a B cell acquire memory without transiting the germinal center? Speak to your friendly immunologist down the hallway, and they will tell you that B cells can acquire memory by bypassing the germinal center in a T cell independent fashion. But wait, there's more. Also described are methylation subtypes of CLL, kind of correlating to some degree with the mutational profile, naive-like, memory-like, and also an intermediate methylation subtype. And in particular, one of them has and many types of CLL, mind you, have stereotypic receptors, but this one in particular, with the immunoglobulin lambda light chain variable reason 3-21 with a specific mutation at R110, highlights a very aggressive subtype of CLL with a recommendation by CLL cooperative groups. ERIC is the group in Europe, suggesting that this be tested for because it's such a poor player in CLL. The methylation subtypes also appear to be more prognostically relevant than the mutational immunoglobulin mutational subtypes. But this is not a widely available or available at all clinical test. And moving on from that, people are now doing chromatin profiling with certain stereotypic subsets identifying aggressive disease. Hairy cell leukemia, fun when you recognize it under the microscope with the circumferential projections, but not always the case. As you know, is a disease that is enriched in a BRAF V600E mutation in virtually, but not quite 100% of cases. And what is BRAF? It's involved in the growth factor signaling pathways and lies just downstream of RAS molecules and other signaling partners. as illustrated in the panel on the right. However, there are variants of hairy cell leukemia, one called hairy cell leukemia variant with prominent nucleoli, another type of hairy cell leukemia that uses a stereotypic V4-34 receptor that actually lacks the BRAF mutation and rather has mutations in MAP kinase, which, as you will see on the right-hand side, is in the pathway just downstream of RAF itself. Other genes are mutated in hairy cell leukemia, so it's not a single mutational disease, and they are listed there, seen in roughly 15% of cases. But all that genetics aside, there really is usually no compelling need to do genetic studies in hairy cell leukemia, since we have a wonderful array of both flow cytometric and indeed immunohistochemical studies if you've got a bone marrow trephine biopsy and no aspirate and no circulating disease in which to make the diagnosis. In my time thus far in South Africa, which, as I mentioned, I've enjoyed tremendously, I've been made aware of some of the austerity measures that sort of preclude your hospitals and laboratories from doing all the tests you would like to do. And in fact, we were not immune to this either. A number of years ago, we had to stop doing immunohistochemistry to save money. And so we had to come up with novel ways to diagnose hairy cell leukemia. And this is a test that I'm very proud to have set up in the laboratory. And we take the specimen of peripheral blood with suspected hairy cell leukemia and incubate it in this reagent. And I've just mentioned as an aside, not only does it work for hairy cell leukemia, it worked wonderfully for me as well. Lymphoplasmacytic lymphoma, Waldenstrom's macroglobulinemia, histologically characterized by, as arrowed at the top, Dutcher bodies, intranuclear cytoplasmic invaginations, the cytology at the bottom showing plasma cells and lymphocytes, plasmacytoid lymphocytes or PLYMPHs in between, characterized typically by an IgM monoclonal paraprotein. Mast cells are frequently seen in bone marrows involved by hairy cell leukemia, not specific for hairy cell leukemia, but quite characteristic in hairy cell leukemia. And they are certainly a very important part and facet of the microenvironment of this disease, with the lymphocytes or plasma cells elaborating CD27 ligand that are nourishing the mast cells. The mast cells in turn elaborate APRIL or CD40 ligand to stimulate and nourish the neoplastic cells. So part of the microenvironment, important part of the microenvironment, are mast cells. As you know, the MYD gene is MYD88 gene, with MY standing not for myeloma, but for myeloid, since this gene was first described and protein was first described in the context of innate immunity in myeloid cells as part of the toll receptor-like signaling pathway. Anyway, is mutated in 95%-ish cases of LPL, but is not specific for LPL, and indeed is found in a minority of cases that may be in the differential diagnosis of lymphoplasmacytic lymphoma, such as marginal zone lymphomas. It's also quite curious, I think, that 30%, roughly 1/3 of ABC, activated B-cell derived diffuse large B-cell lymphomas, harbor the MYD88 mutation. And in fact, it's enriched in certain subtypes of DLBCL, testicular, primary CNS, primary cutaneous, and intravascular DLBCLs, with the top two of particular interest in that they are both DLBCLs of ABC flavor that emerge in immune-privileged sites. MYD88, while the most commonly mutated gene in LPL, is not the only gene that's mutated, with CXCR4 mutated in roughly 30% of cases. And certainly if you find these two genes mutated together, this is very characteristic of LPL. But this is also functionally relevant. MYD88 mutations predict for response to BTK inhibitors, whereas the coexistence of a CXCR4 mutation abrogates that response to BTK inhibition. Mantle cell lymphoma, 11-14 translocation resulting in upregulation of cyclin D1, pushes the cell through the cycle. You don't need to test for this genetically. There's a lovely immunohistochemical surrogate. And although cyclin D1 overexpression is fairly specific, there's an ever increasingly recognized number of other neoplasms that overexpress cyclin D1, formerly called BCL1, including a subset of diffuse large B-cell lymphomas, CLL, in a sneaky fashion can mislead you in that the proliferation centers may express cyclin D1, although usually quite dimly. Hairy cell leukemia, Langerhans cell histiocytosis, Reside-Dorfman disease, amongst others, those histiocytic and dendritic cell neoplasms overexpress cyclin D1. Myeloma expresses cyclin D1. Anaplastic large cell lymphomas are cyclin D1 positive in a subset, and nodular LP Hodgkin or B-cell lymphoma also is characteristically cyclin D1. What about mutations in mantle cell lymphoma? 2 out of the 3 genes are the same genes that are frequently encountered in CLL, highlighting the fact that even the mutations are not that specific, but they're slightly more ATM than TP53 mutations in this disease. Cyclin D1, the gene itself, can be mutated, and depending where it is that it's mutated, may also give rise to false negative immunohistochemistry, analogous to what we encountered in earlier in follicular lymphoma. The prognosis of mantle cell lymphoma can be quite heterogeneous. People have used immunohistochemistry to show either a TP53 expression that is correlated with the mutation, or elevated proliferative fraction as being prognostic. More complicated genomic clusters have been described, not used in clinical practice, although these genes are typically measured. And going from the 4 clusters, the median survival drops from 100% overall survival at 5 years in cluster 1 to a dismal 14% in cluster 4. As is thematic, not all mantle cell lymphomas have the cyclin D1 translocation. So what do we do? How do we diagnose these cases? These are still mantle cell lymphomas. They tend to have translocations of other cyclins, such as cyclin D2, cyclin D3, and cyclin E. However, unlike cyclin D1, which is not physiologically expressed in lymphocytes, as these proteins can be, and so there is not a useful immunohistochemical surrogate, and it can be tricky to diagnose these genetic events requiring FISH or RT-PCR that are not routinely available. However, SOX11 comes to the rescue in that SOX11 tends to be positive in all mantle cell lymphomas, but clearly not all, as we shall see, but that can be useful in diagnosing mantle cell lymphoma that are cyclin D1 negative. With the widespread use of SOX11 immunohistochemistry, it's become clear that there's a subtype of mantle cell lymphoma that's SOX11 negative, and this tends to be associated with the non-nodal leukemic form of mantle cell lymphoma. And although you might predict that a circulating form of mantle cell lymphoma is going to be more aggressive than the nodal form, in fact, this is associated, the absence of SOX11 is associated with more indolent disease. The final disease we're going to talk about are marginal zone lymphomas that come in 3 flavors. As you know, the extranodal forms, molt lymphomas, splenic and nodal. As a group, they tend to be enriched in trisomies of chromosomes 3, 18, and 12, which can be useful FISH assays to do to detect clonality if push comes to shove. They are not specific, however, for marginal zone lymphomas. More specific abnormalities at a mutational level include KLF2 and Notch2 mutations, in particular with the splenic and nodal subtypes, with PTPRD mutations found in the nodal subtype only, albeit in only about 1 in 5 cases. TNF-IRP3, also known as A20, is actually mutated in 50% of ocular agnectal marginal zone lymphomas, can be useful there. With regard to splenic marginal zone lymphomas associated with splenic lymphoma with villous lymphocytes, historically, deletions, interstitial deletions of the long arm of chromosome 7q are fairly recurrent. Genomic clusters have been described, NNK, DMT, depending on the genes that are mutated, have been looked at experimentally, not widely used in clinical practice, or not used at all, to the best of my knowledge. A mimic of some of these splenic marginal zone lymphomas is splenic diffuse red pulp lymphoma, which seems to have its own fairly unique, although not 100 specific, mutational profile affecting cyclin D3 mutations or B-core mutations. Extranodal marginal zone lymphoma, so-called molt lymphomas, a very curious site-dependent association with cytogenetic abnormalities. And one of the most commonly translocated genes in these lymphomas is MALT1. That may partner with BRCA3 to give the 11-18 translocation, or with IGH to give the 14-18 translocation. And as you can see, they're associated with certain anatomic sites. BRCA3 with stomach and lung, IgH with parotid ocular adnexa, and hepatic lymphomas. BCL10 can really be mutated as well in less than 5% of cases. FOXP1, somewhat more commonly mutated in roughly 10% of cases. And again, here we see an association with certain anatomic sites. And in addition to this association with translocations on certain anatomic sites, there are mutations that tend to occur in certain anatomic sites. So, for example, parotid multiple lymphomas tend to have TBL1 XR1 mutations. Ocular adnexa multiple lymphomas, these mutations, including ROA and CABN1, thyroid multiple lymphomas with these mutations, and finally skin or cutaneous multiple lymphomas with FAS mutations, where they'll point out that in the recent classification schemes, these have been downgraded from marginal zone lymphomas, the primary cutaneous ones, to lymphoproliferative disorders, since they have such indolent behavior, in particular those that have class switched. Gastric extranodal multiple lymphomas, as we know, is largely driven, at least in the initial phases, by H. pylori. However, once the 11-18 translocation has emerged, that tumor is no longer dependent upon H. pylori for its growth and existence, and hence it has therapeutic implications that treating with antibiotics at this stage is going to be no help. So these are the summary slides. So we're getting very close to the end. Thank you for staying with me so long. So genetic studies in small B-cell lymphomas, we talked about follicular lymphoma associated with the 14-18 translocation. I've highlighted that it's not essential for the diagnosis. Very useful is the immunohistochemical surrogate, BCL2 immunohistochemistry. However, of course, there are occasions where it is very useful for the diagnosis, especially in cases where we are unable, for either the small size of the biopsy or some variable growth patterns, to determine whether this indeed is a follicular lymphoma. So, for example, some marginal zone lymphomas can colonize the follicles and mimic follicular lymphoma. Sometimes marginal zone lymphomas, follicular lymphomas can show marginal zone differentiation. So sometimes FISH testing there can be valuable. I mentioned also that there are a number of, and growing number of, follicular lymphomas that lack this canonical translocation event. And in such cases, it's almost as important to diagnose or to reveal the absence of the translocation. Mutations can be important prognostically, but particularly so in the cases that are 11-18 negative, since whether they're the pediatric type or the testicular type or the diffuse inguinal type, etc., they tend to have a different portfolio of characteristic mutations that may aid in the diagnosis. Mantle cell lymphoma, 11-14 translocation, roughly 90-95% of cases have it. Again, not essential for the diagnosis. We have immunohistochemistry for cyclin D1, but every now and again we encounter a diagnostically challenging case that may lack, for example, cyclin D1 expression and or SOX11 expression. So looking for the translocation can be helpful in such instances. Mutations are important in mantle cell lymphoma. It's now recommended that TP53 mutations be tested for in mantle cell lymphoma, with some evidence that T53 immunohistochemistry is a reasonable surrogate for that. Gastric multiple lymphomas enriched in, but not exclusively found in, gastric multiple lymphomas are the 11-18 translocation fusing MALT1 with BRCA3. Again, we don't need it to make a diagnosis, but it may be useful for predicting response or lack of response to antibiotic therapy. CLL, SLL, perhaps the one small B-cell lymphoma in which the use of genetic testing is more widespread than any of the others we've spoken about. And we can test for by cytogenetics, both karyotypic analysis, metaphase analysis, but perhaps more useful FISH analysis, number 1 and number 2. Number 3, looking at immunoglobulin gene, variable region, somatic hypermutation. And number 4, looking at mutation of oncogenes, all becoming part and parcel of the evaluation of chronic lymphocytic leukemia. But very importantly, these are used for prognosis and sometimes for prediction of response to therapies such as TP53. Very, very importantly, these are of no value for diagnostic reasons. Hairy cell leukemia, BRAF mutations found in virtually all cases, but really you don't need to test for a BRAF mutation. There are many other ways to diagnose hairy cell leukemia, perhaps only in those patients who've responded poorly or failed to respond to more traditional forms of therapy to see if they have the mutation to justify the use of BRAF inhibitors. Lymphoplasmacytic lymphoma enriched in NYD88 and CXCR4 mutations, most useful for the diagnosis. I think this is another type of lymphoma in which we're more likely to do genetic testing, but here for diagnostic reasons, noting that NYD88 mutations are not specific, can be useful for prognosis in that the subset of marginal zone lymphomas that lack the mutation may have a worse prognosis. Once a CXCR4 mutation has emerged in the setting of an NYD88 mutation, that's important because it may, as I mentioned, diminish the response to BTK inhibition. And so this is the end, or very near the end, of Adam's annoyingly abundantly animated address, but I hope that you now have more mastery of the molecular markers in many of these malignancies. I do apologize, however, for the obnoxiously overbearing overkill with animation and alliteration. I will be happy to take any questions. Thank you for your attention.
Prof. Berg, from our side, thank you very much for a fantastic talk. I think it was a brilliant overview of the topic. So thank you very much. I'll keep an eye on the chat group for any questions or comments. The participants are also welcome to unmute. I see that there are a few comments for you in the chat. Do you have access to the chat, Adam?
I can look, sure. Thanks for the palpitation and exam flashbacks, bad boy bag. That's a little bit too, informal. Can you ask David Richardson to see me in my office, please?
100%. I'll send them an email.
And Rory Shane. Unfortunately, I haven't reached the K-pop chapter yet. We'll be covering it in tomorrow morning session, Rory. I hope you'll be there. And Stephanie Kennedy, who I haven't met, but thank you for your comment about hilarious. And Vernon Lowe is a cycling fan, something about the Tour de France.
All right.
Thank you, Vernon. But no actual questions.
Well, it was such a good overview and everything was absolutely covered. In case perhaps we can have some comments or some extra feedback. I see Vernon has unmuted. Prof. Lowe.
Thanks so much, Prof. Berg. This was really great. I'm sort of wondering from a practical perspective, how you teach your residents or your registrars with all these new things coming along all the time. What do you want them to have? I mean, ideally, we would like to have them have everything in our heads, but I think it can actually become dangerous to try and believe that we can remember all these things. So how do you just practically guide your residents in terms of what would you advise them to keep on board and what should they have at hand and in what format? How do you do this practically? I can see you've got it all up here and probably continuously add in.
You can't see, I've got 15 people sitting around this table feeding me all the information. And in fact, the other one's feeding me the answer to your question. Let me just read the note that they're passing along. No, but I mean, seriously, I think it is challenging. And unless you do this on a daily basis, it's tough. I mean, obviously, I give some didactic lectures such as this, although I don't think I've actually given this specific lecture to the trainees, but I just try and reinforce this knowledge as much as possible in the real world. So when we're looking at a case of a mantle cell lymphoma or a case of a CLL or a case of a hairy cell leukemia, I keep on people, I mean, people, use the word pejoratively, but I enjoy pimping the trainees as much as possible to get them to think about these answers all the time. I can only do so much in terms of the feeding, but the actual nourishing is dependent upon the appetite of the people on the receiving end as well, obviously. So I don't have a simple answer. I mean, people ask, how much of this do I need to know? How much of this do I need to know for the college exams? I mean, there's no obviously simple way to answer that. If you feel like, it's entirely up to the individual. But I don't remember a lot of the stuff I talk about either. I promise you I don't. And there's certain questions you could ask me, and I would say, I don't know the answer. I think it's important to know where to find that information. So it's fine not to know stuff, but I think it's good to know and important to know where you can find that information. And by just being engaged in the field and enjoying what we do and talking about it over and over and over again, eventually some of it will stick. I don't know if that helps.
No, thanks very much. I think that definitely helps. And at least, I mean, we're in such an exciting time. It's wonderful to see how these things more and more will translate into clinical applications as well. But yeah, I'm certainly not one that would remember all of this at all.
Yeah.
Oh,
And I think,
thank you.
Thank you. And again, there's a nice comment from Penny Keene. I mean, I try, and I think we all do as much as possible, not just to talk about CD10 or CD19 or this BRAF or BTK, but try and, become more engaged in terms of what that molecule does for a living, and what drugs are used to target it. I mean, I think, we're all in this together. Sorry. I don't know what
I
else
think
to
it is
say.
it's a perfect illustration of my last comment. Perfect illustration of how important it is for the clinical side and the lab side to work so closely together. As you just said, we really, really need each other.
Yeah, yeah, yeah.
Okay, any further questions or comments?
Unique, we can't let Prof. Berg get off so easily. I am very disappointed in the offering of novel agents that he gave us today. Only minoxidil? What is your success rate with that?
Do you want me to move the camera?
We do like the beard.
Thanks. Actually,
You look charming.
the beard is false too, by the way, but I think it does sort of make me look a little bit distinguished. And I dye it white to look a little bit professorial.
And, we're definitely going to send David to you. So, yeah, lots of discipline in our midst. This
Yeah.
was wonderful. Absolutely wonderful.
Thanks, and welcome back. We missed you the last week or so.
Yes, yes. But, this is a bit like music. It's like a song. And let's see what we can remember in the rhythm of things.
Okay. Actually, there's a private comment from Rory Shane that said he's going to make a composition of this. And we should have it ready for tomorrow morning's journal club. Thanks, Rory.
Thank you, Rory. We're looking forward to it. And then there's another comment from Vernon Lowe, Jacob Collier. Does that mean anything to you, Prof. Berg?
I mean, I think he's obviously testing me to see if that means something to me. And I am happy to say I'm ignorant as to who or what that person is. So please teach me.
They say that Jacob Collier is the modern Mozart. And if anybody want to really be blown away and entertained beyond belief, go and just look at YouTube, Jacob Collier, and go and see what Hans Zimmer has to say about this young man. It's unbelievable. He plays more than 100 instruments. He makes up his own, what do you call it? I'm not a musician, but brand new ways of playing music. He makes new instruments. It's quite fascinating, and the way he plays and sings is remarkable. He won 4 Grammys for his first 4 albums. So
Thanks for sharing that.
I
we're
was
heading-
actually comparing Prof. Bag's level of presentation with Jacob Collier's
Oh my
Uh,
God.
way
Oh,
of
wow.
music. Now you all have to go and have a look. You'll see what I mean.
Yeah.
Excellent. We're heading towards 5:15, so perhaps we could do one more round of any questions or comments. And I think if there's nothing, we'll call the session to a close with thankful hearts and a little bit more knowledge. Let's see. All right, from Belinda Kirk, do folate methylation deficits affect prognosis and susceptibility to these tumors? Folate methylation.
So I'm delighted to have a second question there that I'm unable to answer. And sort of I throw it back out at the audience if someone else can educate me and educate everyone else.
Yeah.
Seems like my ignorance is not unique in that area, which makes it a good question. Sorry, I don't know the answer. We have a Simon and Garfunkel reference. You know, we could go on and on. Thanks, everybody. Thanks for your attention.
Thanks so
Excellent.
much.
Thank you so much, everyone.
Fantastic. Thanks, Unique.
Thank you.
Appreciate it.
Bye.